You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, Assistant Professor of Medicine at Harvard Medical School and physician at the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Jacob Sands, thoracic medical oncologist at the Dana-Farber Cancer Institute. Welcome to Medscape's In Discussion series on lung cancer. Today we'll discuss disparities in medicine with a lung oncology specialist. So first, let me introduce my guest, Dr. Chris Lathan. Dr. Lathan is Chief Clinical Access and Equity Officer at Dana-Farber Cancer Institute. He was appointed to the Faculty Director of Cancer Care Equity at Dana-Farber in 2010 and directs Dana-Farber's clinical outreach work in federally qualified health centers in Boston. Dr. Lathan also serves as the Dana-Farber Network Medical Director and Associate Chief Medical Officer. He is leading the effort to combat structural racism and improve healthcare outcomes for all patients and communities served by Dana-Farber. Dr. Lathan, welcome to In Discussion.
Thank you very much, Dr. Sands. I appreciate the opportunity to be here.
So first, I'd like to start out with a little bit about your journey. Can you give our listeners just a little piece of what led you to this point in your career?
Happy to. I am not a person who thought about medicine early on. My father drove a fork truck for a living, so literally he didn't get out of sixth grade. He worked with his hands all of his life, and so I grew up in a working community. My mother was what we then called a nurse's aide. I think we now would say is a CA. Also, she didn't go to college. And so I went to college thinking I was going to be a scientist, and I really liked reading a lot of books about science fiction, and that's really why I chose it. And then over years, I worked a little bit. I did some graduate school work, and then I really got exposed to medicine when I was working in a lab years later. And I was really interested at that point in bridging all the knowledge I had as a graduate student, but actually the missing component, which was really getting involved with patients. I never knew was an opportunity for me until later.
So we're going to discuss various aspects around disparities, and I find this to be sometimes a challenging topic in that there are some really obvious examples within the healthcare system, but I feel like some of the subtlety is actually where there's the most opportunity. And so I've heard you talk a bit about scenarios with patients where they're talking about one thing and path is going one way, and you've gone back and asked a bit more, and those other bits of information ended up being really critical to really understanding what was going on with that patient. Let's start there. Can you give us some examples around that?
Absolutely. I have this thing that I developed during my training where I think of it as follow the no. It's not that revolutionary of an idea, but I'll give you an example of where it first came to me. I was a fellow and I was learning lung cancer and seeing lung cancer patients. And we had a patient who had a stage 3B come to see us. And unfortunately, we were running late, the attending and I, and the patient had been waiting quite some time. And we went into the room and talked to them about chemotherapy and radiation. This was decades ago. And the patient listened politely and said, no, thank you. And it puzzled the attending and I as we walked out because the person had waited so long for the appointment and really engaged us politely and just said no. So I went back into the room and I asked the patient why they were saying no. And at that point, she said, well, I am taking care of my granddaughter because my daughter has substance issues and I've been taking care of her for years. And the radiation would be during the time that I need to go for the court date. And I'd rather die than miss the court date. And then I sat back and I thought, well, we can change the way we do this. Just because we said that we're going to give chemotherapy and radiation together, we could separate them. And then she immediately said, yes. Oh, that makes sense because she didn't know. I know people think generally when we think about these barriers or kind of people saying no and not understanding, we think about this around race, and race is important. I think in the United States, we talk about race, but this was a white woman from South Boston. So this was about socioeconomic status in class, because some of those things track with race, but they're not the same. And I think this is a good example of someone who I think if you looked at her, people wouldn't have thought to ask that question, but this is a relevant issue. It's more relevant and problematic for our Black and Brown communities, our historically marginalized communities, but it impacts all of our lower income folks, I think, and it's something that we have to think about as clinicians.
So I love that example of a story because I think just as a diffuse topic of how to be a good physician is understanding what's going on with your patients in a way that's not always so clear. One of the things I say that I think is one of the most important jobs as an oncologist is to understand why my patients are making decisions when sometimes they don't fully understand that, or what their beliefs are around what's going to happen and how that's impacting their decision. Now, that's much more clear when we're talking about something like many patients come in thinking that chemotherapy is just to prolong their lives, but at the expense of the quality of life. And of course, our treatment is meant to improve people's quality of life, even when we're giving treatments with some side effects. But this example is something deeper than that, but related in that the patient thought that, if she gets that treatment, she's not going to be able to complete the adoption, and therefore she doesn't want to do it. Now, but that raises another topic maybe to explore. And let's start out with, when we're talking about disparities in medicine, what's kind of the framework of even navigating that discussion?
I think it's really important for us as clinicians, especially as cancer clinicians, and specifically, it's really relevant to us with lung cancer. But let's back up and answer your question. So the idea is access to care impacted, and is quality of the care received impacted by barriers, right? And I think that's at its very root. When you think about disparities, you think about treatment equity, that's what we're talking about, right? Can all people have access to care? And we know that we're in a system where that is not true. Not everybody has the same access, right? And I think if you think about insurance, we understand that. We try to work around it as clinicians. And then you start to say, well, what role does race have in it, or language? And I think when you start to look at historically marginalized communities, and Black and brown communities, African-American communities in the United States are one of those, Indigenous folks as well, or another group where there are so many structural barriers limited throughout. And then you add on some of the trust issues, even the way that referral patterns happen, where the cancer center hospitals are located. These things that we as clinicians don't always see as barriers are really major impediments. And then on top of that, as oncologists, I think we assume that people are going to stop their lives, and this cancer diagnosis is the worst possible thing that can happen to them, right? And they're going to marshal all their social supports, and they're going to fight this battle, because that's what we've seen. But you have to recognize that for some people, and it can be race agnostic, but it does tend to track with historically marginalized folks, the cancer might not be the worst thing in their mind that's going on. Maybe it's they're going to lose their house. Maybe it's something else that's happening. And I think for us, that's a hard concept to take. And that could explain a lot of these behaviors that we get concerned about, missed appointments, et cetera. There are other things that are going on in this person's life, and we don't usually get the training to think about how to ask or address them.
So when you're working with residents and fellows or med students, how do you introduce this topic, or how do you explore this or help others to really see what might be missed? Like the patient you just described, where everyone walked out of the room and she was not going to get a curative intent treatment, but you went back. Where do you lead the discussion for your trainees?
I think this is one of those things that links to the communities I came from and informs the approach that I have. You know, my father worked with his hands, you heard me mention, and he passed of congestive heart failure, but nobody knew he was sick until he didn't go to work one day. He always went to work. He worked multiple jobs, and one day he called into work, and that's when my mother knew there was something wrong with him. And so coming from communities like that, I have been lucky enough to think about that approach when I am doing my clinical work. And that's what I try to help the fellows with and residents with. When you go into a room and you talk to somebody, and they come back out and talk to me, and they'll tell me about the disease, and I'll say, who do they live with? Did they serve in the military? This person a veteran? You know, things like that. I think in the beginning, sometimes people are saying, how does that relate to this cancer at hand? Here's a molecular signature. But of course, a lot of it matters. Who's in the room with that person is the number one question I ask. Who's in the room? And is there somebody else in that person's family that helps make decisions? Those things really do impact how we are able to build trust. And it matters in a really, really important way, practically, for patients. So I do try to show it that way, not just like, did you take a social history, but did you understand? And I'll give you another example. I was on service and there was a woman, an elderly woman, and she was by herself. And the consult team had come in and given her diagnosis. But she was all alone in the hospital and might have even had some early cognitive issues. And I think sometimes we get so busy in the hospital practice, we come in and we sit down at the bedside like we're taught. We look the patient in the eye and we calmly tell them that the pathologies come back. This is in inpatient setting. And this patient was so overwhelmed because didn't know where to place it, didn't know how to deal with it. I think sometimes we as clinicians who are immersed in this every day can forget and say, hey, no, we got to come in. Is somebody on the phone? Will somebody be there? That's the thing that I try to bring to all of us. And I forget too, we're busy to try to remember these are humans that have a whole bunch of other things and structures there that are important. And we don't have to fix everything, but we have to be able to think about it. And it allows us to think about how we deliver information, how we deliver our treatment plans, et cetera.
Yeah, I find it's really important to be curious and present. And that can be really hard when you have such a long ongoing list of things you have to get to in the hospital. I mean, I remember, especially as an intern resident, you've got this long list and I'd have my little boxes that I need to check next to thing. And if you're going into a room with that running list in your mind, I think people can feel that. People can feel when you're truly present with them. I believe that has an impact on how much they then share or how much they talk about what's going on or how much they trust. Some of these things that actually are really hard to measure about interactions with patients. Anytime I'm going into a room, I try to kind of take a breath and drop everything else so I can really just be there in the room and then pick it all up when I walk back out again or kind of try to remember what that running list is. As a medical student, I had an attending who talked about knowing something from the social history. It was just getting a sense for who that person is or adding another dimension to this individual that you're taking care of. Now, you've defined some of the things that you say to trainees to understand about whether there's somebody with them in the room or recognizing these different things. What would you put as kind of 3-ish things on that list and how that impacts what you're thinking about in the next stages of care?
That's a great question. I think the first thing I like to know is what's their understanding of their process. You can get that by asking people, what's the reason you think you're here? And for us in the lung cancer space, especially for those of us who are subspecialists, that's the first question I go with. And in that, I start to get some sense of their understanding, their relationship to medicine and their relationship to their primary care, if they have one, that sort of thing. The next question I like to ask, who's with you? Who do you live with? And that gives us what's going on with your social situation and what do you need, what help the patient might need. And then the last thing I tend to ask at the end is I try to get a sense of some sort of, whether it's where the people live and where they're from. I'm not trying to fill out something specifically, but are you from this area? Did you grow up in here? I see you live here. The questions like that can give you a sense of where the person came from. And of course, occupation and all that, people generally forget to ask these days, but I always ask it because it's important. And again, as you know, in lung cancer, with the stigma of lung cancer, it's really important for us to get to some of these things. So those are the things that I always try to remember to ask. And it gives you a fuller understanding of who the person is in addition to their disease status.
So now what would you say when focusing particularly around disparities? What are some of the specific things that you might recognize from that interaction or from that history that leads you to think about things differently for that person or make sure that there's some aspect of care that you're being attentive to?
Yeah, I think all of us, we're going into a room and we have a job to do and we're thinking about how we're going to interact. And we're assuming that the way that we've interacted the majority of the time is going to be the way that it works for this patient. I think all of us as clinicians in lung cancer, we can recall times where whatever process, and myself included, doesn't work. I think when you're looking at race and when you're looking at especially historically marginalized folks, I think there's this idea that you can kind of come in and know everything about a community. It doesn't necessarily work that way. What really is important, and I got this from other clinicians, I'd been asking a senior clinician who was working in New York City, and she was a white woman and she did not know Spanish when she first got there. And she had this incredible connection with her patient base. I said, how did you do that? And she said, well, the most important thing I did was learn Spanish. And the second thing I did is just demonstrate every day that I was present and ask questions about them and that specific community. And then the trust was built from there. And I think that's actually the key. I think we have been taught to back away from some of the structural barriers in medicine. I think when I was training, people didn't want to talk about social justice. We didn't really talk about the barriers as much, in a sense, thinking that's somebody else's problem. What we know now is it impacts so much how we deliver care. Remember, we used to say a patient is non-compliant. The patient is a no-show. And we weren't really thinking about, well, why is that happening? And how are people being referred and what's happening to them? And, I think that is a shift. If you really talk about patient-centeredness, most of the time that's been around patients with voice. And by that, I mean patients who have education, patients who have means, but you don't have to be wealthy, but an ability to say, this is what I need and this is what I want. And those patients really have to find the encounter, which makes sense. But for those patients who don't have voice, whether that's a cultural issue, whether that's socioeconomic issue, whether that's a racial issue, those folks, we don't really build care around those folks. And I think that's the trouble with our system right now is it's hard to deliver care if we don't really take those factors into account. And then it ends up excluding folks, even when that's not your intent consciously. The system already has built in some exclusionary barriers.
And now once you've recognized somebody with a barrier of some kind, as you've described, then what?
Yeah, so this is what I call the nihilism, right? Oh my gosh, I'm just a clinician here. I can't fix all of this. And here's the beauty. We don't have to fix all of this. I wish that we could individually fix it, but there are a couple of things. There's a paper that we published years ago that was looking at a data set that we called the CANCORS data set. It was lung cancer and colon cancer patients. It was a pretty simple question we asked. What happens if basically when patients don't have enough income in their lower income? People always talked about how cancer decreased your income. In a sense, cancer makes you poor. Well, what if you were already under financial distress or duress before your cancer diagnosis? And in that paper, it showed some things that are not going to surprise people. You're more likely to present with more symptoms when that happens. And this is just based on the income. Yes, it's worse. It's an additive or synergistic effect for African Americans and for other historically marginalized communities, but socioeconomic impact, right, is powerful. So not only are you presenting with worse symptoms, and in lung cancer, it was a little bit more shortness of breath and a little bit more pain. In addition to that, we found that people weren't asking the questions because there are some services that sometimes you can help. So one of the things that the take home for that paper was we should be routinely assessing barriers because many of the cancer centers have money or sources of money that can help people proactively. Generally, the only time we trigger those services is when a patient asks for it in the room. Or, for example, one study said that the physician will activate services like this when the patient is crying or in distress. And we go, oh my goodness, let's call social work. Oh my goodness, let's do this. So if the system or the EMR or your process has already asked these questions, you could already start to activate the support services that can be targeted for your patients that need it the most. And then the second part about that is what can we do? Well, if rides are the problem, let's see what we can do with the resources we have. We understand it's not going to fix every problem, but even working to fix some of those problems, build your therapeutic relationships. It gets the patients closer to the care, given the way we want to give it to really deal with the problem, and it will lead in the end, I believe, to better outcomes. Now, I don't have a paper that says that. We do have a paper that shows that navigation, when targeted specifically for those who need it the most, does decrease the time in between, whether it's for screening or resolution. So there is some indication there that we can do something as a system. It doesn't have to be just the physician, but we as decision makers in the system should be aware what's in our system for resources, what can we do, and get the rest of the team involved. So it doesn't have to be just on the backs of that physician in the room.
Now, recognizing that this is going to be different with different resources in different institutions, different states, is there anywhere you can guide our listeners as to where to look into this further?
So I think the advocacy groups, and if you think about lung cancer and you think about going to some of your advocacy groups, that's helpful. But I do think when you're talking about in the room with your patient who needs some help, I think the first thing is to have what I call landscape survey. What does your institution offer? and somebody in your team, and sometimes it's nursing that really knows that. Sometimes it's a social work team. Who do I refer to if the patient has these issues? As you point out, different states have different barriers. There's some states, especially the states that haven't expanded ACA, then your ability for patients who are on Medicaid to see folks at an institution might be limited by law. And then patients might have to go to a different system, right? A safety net system. That's a bigger issue to think about how we can help with that. That being said, if you know that up front, and if you know what you can do and how you can help patients to make sure they're still diagnosed appropriately, if your system has an issue with that, or if there is, you're in a state that hasn't expanded ACA, again, at least knowing where the safety net hospitals are, how they're united, and when you can do bone marrow transplants, or what are the loopholes or the places where the urgency is so high that we're able to give the treatment even with those barriers. So I think you can know your system, and you know who knows this? The access management people in every hospital. They have to know, right, to keep the lights on in the hospital. So I think we can say to people, hey, I need to know who my support people are. I need to know how I can support my patients. What resources do we have? And what are the limitations of those resources? Because if you're upfront with patients, they understand that you can do only so much, but man, there's so much that we can do. And then we can advocate and use our power as physicians, if that's something that's important to you, to try to think about how do we rectify some of these issues and make sure that, yes, everybody feels like they're trusted, but more importantly, we want outcomes. Now that our drugs are better in lung cancer, it really matters that people get the drug when it's appropriate. And this, I think, should appeal to the intellectual side of anybody to think, I have a drug, the drug works. How come I can't get it to the right people? It shouldn't be impacted by the language you speak, the zip code you came from, the color of your skin. We should be able to figure that out. And yet study after study after study is showing us in our own disease, in lung cancer, which has made so many improvements, this is still a major problem.
There is an increasing acknowledgement of structural racism within our society. And that could be a hard topic to really dive into, because I believe that the majority of individuals within society that are acting in ways that can support that structural racism actually believe in equality for everybody. And this can all happen in ways where there's not entire awareness around that. And so how do you start diving into that topic around structural racism and the effect on medicine?
Yeah, I think in my career, when I first started talking about barriers, because everybody understands that there are barriers. Everybody understood when we were talking about the impact of the social determinants of health. People understood that. And they understood the impacts of the built environment. So I think it's really saying structural racism, those words in particular, and social justice. Those words, for some people, sound like activism. And I think medicine always thought of itself as kind of above and beyond politics. I think most individuals will say, hey, look, I'm interacting with my patient. I'm not making any conscious decisions to be difficult. I want the best for my patients. And I think that's, my own opinion is I think that's how most people are, whatever their individual race is. They're not trying to, cause any trouble. I think what's hard conceptually is that there can be a system where if we say it this way, if we are with socioeconomic status, if you don't have means in this system, we know that you're disadvantaged, right? We know that. And I think if you look at disproportionately who has less means, it tends to be, Black and brown communities and indigenous communities. And then if you say to yourself, well, why is it that is happening? And you go back and look at the structures that were built, intentionally or not, that gives you some answer there, right? And things are certainly better than they were, but the infrastructure is still there, like redlining, insurance, and, why are communities like this? Well, it wasn't just an oops. It was a conscious decision to construct cities a certain way by banks and real estate agents. And so all of these things are things that none of us learn until much later. I think if we pull back a little bit from the politics and think about it as clinicians, I want to build the best system for folks. And I'll say this other thing. You look at what happens to white folks in Appalachia, their outcomes are just as bad as poor Black and brown folks. Why? Because it's an isolated community that hasn't been able to have the attention or the voice to make things move forward. In lung cancer, look at the tobacco belt, right? And look at the outcomes for all patients, Black or white, and they are lower in the places where tobacco is highest in the states that didn't expand ACA. So I guess what I'm trying to say is, yes, I do think that we have structural racism and structural classism. And those things are parallel, but not the same. And I think that if you talk about language and how language impacts people, how come we can't get so-and-so on clinical trials? And then we find out, actually, the clinical trial language for a long time, it said patient had to speak English. And even now, when people say, oh, it's not like that anymore, but the PIs can't get the $3,000 it takes to make sure that consent is translated. These are problems of inertia, not necessarily problems of constant and acute barriers that are being put up. These are things that are there. But once you see them, we might have an opportunity to remove them. And then that can make it better for everybody.
Well, to look a little bit more at how race can affect the care, do you have any examples for our listeners of where you can provide some kind of direction on how this may have impacted the way that clinicians were seeing their patients or what they were expecting amongst physicians that want to take good care of patients?
Yeah, Jacob, again, and when I was training, and at this point I was a resident, I was in the CCU. Unfortunately, there was a young man, it was a young African-American man who was in his 20s, and he had his heart stopped while he was playing basketball. And he'd been down for a long time. And they came in to the ICU, and he was intubated and on pressors, and it was pretty clear that, there wasn't going to be a good outcome. And because it was a big faith community in the ICU, there became this gathering of, maybe like 10 or 11, 12 people who wanted to come, and they wanted to pray around this young man. And the nurses and the clinicians there started to get a little agitated because there were people who were coming in and they were starting to pray loudly. And the idea was like, could you please be quiet? Of course, as you can imagine, the family members are thinking, I'm praying and why are you bothering me? And it started to get more and more heated. And I was not directly involved in the care of the patient. I was watching from the other team. And I came over and I ended up talking to the charge nurse. And this is what I said. There was another patient who was in that ICU who was experiencing steroid psychosis. And this person was also a physician, and that person's spouse was a lawyer. And that patient had been experiencing, because of psychosis, really outrageous behavior. But everybody seemed to understand and give a lot of support and understanding to the outrageous behavior, because they were all thinking, well, that could be me or that could be my spouse. And so when I talked to the charge nurse and some of the other clinicians, I said, I think I know what's happening here. People, this is an evangelical community and they're praying. I think if we just talk to the family and say, hey, instead of stop praying, the majority of the family can pray in the waiting room, and maybe just one or two people could pray a little quietly here because we're trying to keep the noise down, instead of calling security, which is where this was going to go to. And I was able to go ahead and talk to the minister who was there. And of course, everybody was understanding. And the charge nurse came back to me and said, I thank you for doing that and pointing out, it wasn't just saying this thing that was happening with this young African-American man was not great. It was saying, just take a minute and see how you reacted when some of the outrageous things this other patient did, when you felt you could understand it. And it was a really good learning moment for everyone. It taught me that there's a way to talk about this where people don't have to be defensive and upset, and it could be great for the patient. And I think, hearing from the nurses saying, oh, thank you for telling us that in that manner, let them know, like, oh my goodness, I didn't realize this was happening. Sometimes we don't realize it, and it's okay to learn. I've learned, we all learn, and we need to have a little space to do that. And I think if we can create a little space to focus on areas that might be a blind spot for all of us, and especially as we talk about racial disparities and equity, it's really important for us to be able to do that so people can learn and we can give them the tools to grow.
Yeah, and that ties back into everything you said in the beginning, really, of taking a history and understanding some of the background. And one of those was religious. Well, today we've talked with Dr. Chris Lathan about disparities in medicine. Thank you for tuning in. If you haven't done so already, take a moment to download the Medscape mobile app to listen and subscribe to this podcast series on lung cancer. This is Dr. Jacob Sands for In Discussion.
Thanks for listening to Medscape's In Discussion Lung Cancer podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on lung cancer.